For those of you who don't know me, my name is Ryan Khanna. I'm one of the spine fellows here at SCSF. And today I'd like to talk about uh, a little bit, delve into subaxial cervical spine trauma. So just a brief outline of the topic today. I'll start off with just kind of an intro of the epidemiology and anatomy of the subaxial cervical spine. Some of the different classifications, focus on two of them, of how to classify subaxial cervical spine trauma. The additional steps to assess and what imaging to do, the role of, which is kind of controversial, the role of steroids, a little bit more about the mechanisms of the trauma, including compression, teardrop, facet injury, and then what to do in classical spinal cord injury, and if that changes how we manage these patients. So, wanted to first talk about kind of the anatomy of the subaxial cervical spine. So, by the name subaxial, refers to the C3 to C7 vertebral bodies, both the anterior and posterior elements, and it is divided into different vertebrae. For example, C3, C4, and involves the complex of a intervertebral disc, the vertebral body, the posterior arch ligaments, as well as the facet joints. In the subaxial spine, the facet joints are usually together by a 45-degree angle. And as you go up from C7 to C3, that 45-degree angle increases. There's a couple different theories about how the subaxial spine works, but mostly divided into either the two-column by the hole towards the Punjabi, the anterior posterior, or the three-column theory, as described by Dennis. The anterior column in the anterior posterior Punjabi classification includes the ALL, the annulus, the vertebral bodies, as well as the transverse process in PLL, versus the posterior column refers to the ligamentum flavum, facet caps, pedicle, lamina, spinous process, and the PLC. In terms of stability and what we classically repair in these traumas, most of the stability is conferred in the anterior column through the discal ligamentous complex, versus in the posterior column, it involves the facet joints. And usually reconstructions, when the spine is considered unstable, involves repairing these different complexes. There are some other aspects to know about, namely that the vertebral artery runs through the foramen in the cervical spine, so that can lead to injury, both management of the injury of the vertebral artery leading to dissections, as well as we need to be aware of when you're placing your implants in, that there's no damage to it. When you're managing subaxial spine trauma, spinal stability is the most important goal in the management of it, and kind of guides our management and treatment options. And as you can see here on the right X-ray, the sagittal cut, you can see the anterior, what we see is by the Punjabi theory, the anterior element and the posterior element, like I mentioned before, involves both the disc space, the annulus, both the anterior, posterior annulus, the PLL, the ALL, and the posterior element is everything behind that. So the facet, the ligamentum flavum, the interspinous ligament, the lamina, and the spinous process. So next, I wanted to talk about the different kind of classifications. While there's many of them, the ones that are most popular include the Holsworth, Allen, Ferguson, Harris, White, and Punjabi checklist, CSIS 4-column, the SLIC, SLIC, and AO spine. I'll talk about the last two today. And most of these all are centered around trying to classify the mechanism of injury: compression, burst, flexion distraction, facet dislocation, facet fracture, flexion teardrop, and extension teardrop. And most of these classifications involve some sort of radiographic descriptive classification of the mechanism of the trauma. Because these injuries are so heterogeneous, can be difficult, which is why you can see there's so many different kinds of classification systems. So today I'll just focus in on the last two. So first one is SLIC was started in 2007 from the Spine Trauma Study Group. and was developed using a combination of literature review, retrospective review, and expert opinion, and then applied to cases. And was kind of a modification of the TLIX, which is, I think, a little bit more popular and used in the thoracolumbar injury. And what they wanted to do is they wanted to include different things to kind of come up with an overall point score, and using that classification, come up with, if it's less than 3, that's considered a non-operative case. If it's 4, it's surgeon discretion, and if it's greater than 5, it would be leaning towards operative case. And what they looked at is number one, morphology. So looking to see if the pattern of spinal cord column disruption, on if that would push you into operating with compression being the least severe out of the injuries, and a rotation translation being the most severe. Seeing how the discal ligamentous complex, if it had integrity or not, represented by, I kind of talked about in the anatomy slide in the last, whether the anterior and posterior columns were disrupted or not. And then neurologic status, which, as we all know, is very important. And incomplete cord injuries are, especially in the setting of a continuous cord compression, structural cord compression, will push you into to operating. One important thing is that the discal ligamentous complex is different in this classification versus TLIX, in that it includes both the intervertebral disc, the anterior and posterior longitudinal ligaments, versus in the class of TLIX, which is focused on the posterior column. And neurologic status, what they come into when they present to you, is the most influential predictor of how they're going to do after, whether we treat them non-operatively or operatively. And like we can see here, just another slide showing that this is external validation, showing that for this group studied, basically looking at a retrospective review of 185 patients that presented to a level 1 trauma center in Australia, and they looked at retrospectively how those patients' SLIC scores were, and wanted to see if that what the scores retrospectively calculated were, if they correlated with what the ultimate choice was. And it looks like in this paper study that they did agree, because for all the scores that were less than 3, they ended up taking 95% of them were treated non-surgically, and for those that were greater than 5, 95% of them were treated surgically. And in this case, for the patients that are treated non-operatively, most of them were put into a rigid cervical orthosis for 6 to 12 weeks. However, there are some issues, and there were some poor observer reliability with this classification. So in 2016, the Vaccaro group decided to basically come up with a new AO spine classification system. And this system was based on injury morphology instead of mechanistically like the prior systems. Because in the ESSA classification, users had difficulty agreeing on injury morphology. In this group, they basically came up with a classification based on 4 different criteria. Morphology, so similar to what we presented in the prior classification system, whether the facet joint was injured or not. The neurologic status, the main thing, as you can see here, where that table with the NO starting with neurologically intact, the main thing is they had a plus modifier, saying that if there's ongoing compression in a setting of incomplete neurological deficit or nerve injury, we have a plus modifier. And then case-specific modifiers, looking to see that things like critical disc herniation, if they had a stiffening or metabolic bone disease like DISH or ankylosing spondylitis. And it showed that compared to the SLIC, it had an increased reliability among users. Just wanted to delve in a little bit more, looking at different types of injuries. Looking at from the left to right, deferred to from a compression injury, from minor non-structural fractures such as isolated spinous process or isolated lamina, going all the way down to a complete burst fracture. And this was just classified from least severe to most severe. B was a tension band injury, and referred to from B1 being a posterior a bony tension band injury, B2 referring to if there was an angulation causing angulation between the different subaxial spine, and then B3 was an anterior tension band injury. BL referred to bilateral injury, self-explanatory. C, most severe, was a translation injury, translation of one vertebral body relative to another in any coronal or sagittal or axial rotation. And then type F referred to whether they had facet injury in addition to a vertebral body injury, and range from F1 being a non-displaced facet fracture all the way down to F4, which was a pathological subluxation or a perched or dislocated facet. Like I said, it had improved reliability compared to the SLIC. So what do we do when these patients initially present? As always, learn from the first day of medical school. ABCs are the most important thing. Airways, breathing, circulation. I want to make sure that that's all satisfied before we start looking at what happens and how to manage the cervical spine trauma. Assuming that's taken care of, first thing to do is, in most times we're not called, but this is done by the initial trauma team. But they're doing things like looking at cervical posture, seeing if palpating the entire spine, cervical spine, all the way down to thoracolumbar spine, and assessing a initial neurologic exam. During this process, also want to make sure that we're looking for associated conditions that would guide our management. Like I said in the last slide, this is in this case-specific modifier. So these stiffening metabolic bone diseases, things like ankle spondylitis, DISH, seeing if they had a prior fusion, if they have ligamentous laxity. And for us, one of the most important things is both orthopedic and neurosurgeons is you want to look to see what the neurologic status is, because a lot of times, and I'll talk about this more later, but closed reduction can be done using Gardner-Wells tongs and weights, and these can really only be done in patients that are neurologically intact and cooperative. So a lot of times in my residency, I saw patients that were alcoholics or otherwise had other metabolic disturbances, and if they come in with subaxial cervical spine trauma, it can be hard to do these closed reductions and unsafe unless you have an MRI prior to doing that. Starting from quickest to most invasive, starting radiographs can be done, but in the current paradigm, CT is the gold standard. Any patient with a high enough mechanism of injury and a neurological deficit or unknown trauma with other signs of high mechanism or high speed mechanisms, or usually get warrant a CT scan. It's a gold standard. It has a sensitivity of 99% and a specificity of 100% of diagnosing subaxial cervical spine trauma. The controversy is whether there needs to be an MRI done or not. There's all these rules. In my residency, the ER usually in trauma bay usually use the Canadian C-spine rule to clear collars, but MRI screening is more controversial and usually is referred to higher risk patients or patients that have a higher mechanism of injury. MRI screening, a study in meta-analysis in 2008, as you can see, the title says MRI is unnecessary to clear the cervical spine in obtunded comatose trauma patients. They saw that if you had a normal CT and with no evident neurological deficit, that didn't really add much, that it only found 21% of injuries that weren't in addition to the injuries found by CT spine, and none of those required surgery. But however, for patients that are older, that are obtunded, that have spondylosis, have a deficit, known fracture, or that were taken in the operating room, it's something to order. Additionally, as I talked about on the anatomy slide, the vertebral artery is obviously involved in this region, and a CTA is warranted to look for vertebral artery injury. And if there's a dissection, it can sometimes even be need to be treated endovascular or be placed on a 3 to 6 month antiplatelet regimen. So it's good to know prior to treating them either non-operatively or operatively if it guides your medical management. Next, I want to talk about a more controversial topic, which is steroids. There's been many different studies looking at this. Today, I wanted to focus on the NASAS 1, 2, and 3. And where I trained, the two places I trained before, and I started my training at the end of 2016. So kind of when these studies came out and these consensus guidelines came out. But in my training, I've never really been trained to use steroids in spinal cord injury. But these are kind of all came from these studies. NASAS one looked at um, the difference between low and high dose methylprednisolone and demonstrated no difference between the groups. Although 70.6% had improved motor scores, in the high dose groups, they had a higher rate of wound infections, trends towards sepsis, PE, and death. So then in the next analysis, they looked at if you steroids, was there's any difference between steroids and naloxone and placebo. And post hoc analysis showed that in this group that patients treated within 8 hours showed a 5-point improvement in motor score compared to patients receiving steroids after 8 hours. And then NASAS 3 showed that there was no difference between 24 and 48 hours of steroids, and post hoc motor improvements were usually confined to those who received the infusion between 3 and 8 hours of injury. And also showed that there are downsides of using steroids, including prolonged steroid use leading to severe pneumonia. In 2017, the AO group looked at kind of all of these guidelines, said that there was no differences in motor score changes at any time point. However, if steroids were, methylprednisolone was administered within 8 hours of injury, there were modest improvements in the mean motor scores. So kind of talking to friends at other institutions, it sounds like kind of their consensus is that if you are going to use steroids, you got to use it in young patients who came in with a more recent injury versus there not being much of a role in a delayed spinal cord injury. And in their official guidelines, we suggest not offering a 24-hour infusion of high dose to patients who present after 8 hours, but it can be considered for patients who are presenting within 8 hours. Next, let's kind of talk about some of in the AO classification, some of the actual injury patterns and the mechanisms. A lot of patients we see, especially at the La Jolla Memorial, usually come in with some sort of compression burst injuries. If they're usually non-operative, they're mild. If they have an intact posterior column, including the posterior ligaments, and no significant angulation or kyphosis. However, things that can lead you to take it to the OR would be that if it's unstable based on one of those classifications, or there is ongoing spinal cord compression. Usually, these are treated through the anterior column, usually anterior decompression with a corpectomy if needed, and can be done usually using an expandable cage versus a strut graft. It involves fusion with instrumentation. Next, I want to talk about deflection teardrop versus extension teardrop. These are two different mechanisms leading to two different radiological findings. In the flexion mechanism, what ends up happening is with the severe force of the flexion, the anterior column fails. And what ends up happening is sort of these larger anterior lip fragments that are called quadrangular fractures result. These are pretty severe and are associated with spinal cord injury and posterior retropulsion, which leads to us to operate on to decompress and to stabilize. And if they are unstable, you can stabilize them either anteriorly or posteriorly, depending on the etiology. And the extension injuries refer to patient being in an extension, high force of extension, and result in an avulsion of anterior end plate. Most are stable and can be treated with a cervical collar. However, if there is a large avulsion of the anterior end plate, a DLC injury, a neurological deficit, those are all things that require us to take these patients to the operating room. The facet dislocation, these are things that are, at least in my experience, are things that when patients present with the subaxial cervical trauma are things that we take most emergently. And there are a algorithm that can be followed. But what you can see is with a facet dislocation, because of the injury, what happens is the superior facet then, because of the injury, then lies anterior to the inferior facet. And in the bottom right, you can see it's called the reverse hamburger sign, and you can see that on the CT scan in the axial plane. What the controversy and I kind of refer to, really depends on the neurologic status of the patient. But in a lot of these cases, the first thing we want to do is do a closed reduction using Gardner's well tongs. But what the controversy revolves is whether we should do an MRI before or after, because in some of these patients, and in some studies showing that it can be up to 50% of patients with facet dislocations also have a herniated disc. So what you don't want to do is to do a closed reduction and make the disc herniation worse and cause worsening of cord compression. So different groups advocate for getting an MRI before or after a reduction. For patients with a bilateral facet dislocation or jump facets or perch facets, like I said, closed reduction usually is the first thing that we want to think about. But other treatment options, including Halo, and I feel like more recent years, there's been a push to take these patients more to the OR and do an operative reduction and fixation. And usually closed reduction is just a way to kind of temporize until you can take the patient to the OR. And depending on what the scan looks like and what the patient's symptoms are, usually is either anterior, posterior, or in a lot of cases combined. Looking at a study, they looked at the effectiveness of surgical versus non-operative management of unilateral non-displaced subaxial cervical spine facet fractures. And most of these patients were taken to the OR after non-operative management failed. Most of these cases were 96% of the patients were at C6, C7 in the subaxial spine. 15 of these patients were treated non-operatively, 10 were treated operatively. Operatively, only one of them failed fusion, versus in the non-operative group, only 6 fused and 9 failed. So if there's any doubt, I think most of the time we're taking these patients to the OR to fuse them. Finally, we want to talk about spinal cord injury. And currently, Central Core, and Dr. Mundus and I recall this past week and actually had one of these patients present on Friday night. But the current WNS CNS spine section recommendations are for patients who present with central cord, and because of the injury, as you can see on the topographic map of the spinal cord, where the region of the central cord is usually where the hand motor pathway is, and that's injured, which results in classically patients who are not able to use kind of their distal upper extremities or their hands. And like I said, we had one of these 33-year-old patients present on Friday, and usually what studies have shown is that that surgery can lead to a shorter hospital stay and a faster return to neurological baseline, but at long term, doesn't really have significant neurologic differences between the groups. If there is mechanical instability or ongoing cord compression, that'll force you to take the patient to the OR sooner rather than later. But kind of what the paradigm I've been taught since I've done residency is that if the patient is getting better or improving, something that you kind of just want to treat with elevated maps and let the cord be perfused, versus if they're not getting better, that's something that you want to take them to decompress and fuse. Lastly, want to talk about kind of the evidence of a lumbar drain. In recent years, there's been more studies looking at instead of looking at map goals, why don't we look at kind of spinal cord perfusion pressure goals. Intracranially, we look at this all the time when we're looking at basically how much blood gets to the brain. We'll look at the difference between ICPs and the map. For similar idea, putting in a lumbar drain allows you to measure the intrathecal pressure and can come up with spinal cord perfusion pressure, which is the difference between the maps and the intrathecal pressure. On the bottom, I have an algorithm that one of my colleagues at University of Toronto is doing a study called Casper at. I want to include this into it, but basically they're putting in lumbar drains for all these patients with spinal cord injuries, and based on the intrathecal pressure, they are either draining to decrease the intrathecal pressure if it's higher or greater than 15 millimeters of mercury. And then if it's low, they're targeting maps based on this new spinal cord perfusion pressure. Out of where I trained Rush, they published a correspond is basically looking at a meta-analysis of the 4 articles, looking at lumbar drain, and overall it appears to be pretty safe. So more and more centers are starting to put these in for patients with spinal cord injury. And from that article, these are the 4 articles, and while there aren't a lot of patients, there's 145 patients. All of them show to have a very minimal risk of complications. Overall, for patients with subaxial cervical spine trauma, close to 90% of them have a 5-year survival. Patients, just like any other disease we see in the spine, if they have advanced age, if they have severe head injury, if they have severe spinal cord injury, more likely to face mortality. Depending on the study you look at, between 10 and 20% improve 2 ASIA grades from presentation. 51% improve 1 ASIA grade, and most patients improve in radiculopathy symptoms. Patients do complain of neck pain with a medium VAS next score of 1, and 98% of patients fuse based on the study out of Scandinavia, looking at 303 patients. So just in conclusion, when evaluating these patients, you need to understand the anatomy, knows what makes it different than the thoracolumbar and the upper cervical spine. You need to have a classification that you reliably use. In my experience, it looks like the AO spine is probably the most reliable between different observers. Know how to manage these patients both non-operatively and operatively, and goals are to stabilize as well as to maximize neurological recovery in these patients. All right, and these are my references.
Thanks, Ryan. Great summary.
Yeah, it's good. You know, several years ago, one of our fellows named Randy Lubeck and I looked at doing CSF drainage in the middle of VCRs. So we actually put a catheter in distally and would drain the CSF during the VCR to see if it helped with, you know, avoidance of, you know, signal changes and stuff like that. It was interesting. We used ultrasound, kind of looked at the fecal sac, looked at where the spinal cord was. Kind of a cool study we did. But it's fascinating to think to do that prophylactically, but maybe totally the right thing to do. You know, I mean, the cardiac guys do it, right? In a lot of their bypass patients to avoid,
Yeah, I mean,
you know, the spinal cord stroke and stuff like that.
Yeah, I mean, yeah, we were getting residency, we were getting consulted by the end of residency on every single T-bar they were doing for that specific reason. So I think it makes sense intuitively.
Well, thanks, Ryan.
Dr. Mundis, real quick, did it help at all? Like, what did you guys find? Anything interesting?
We found some just like some anatomic stuff, but we actually only had one patient that had signal changes that we could even evaluate, you know.
Yeah.
So it wasn't, we didn't have enough patients in the cohort really to help, but I mean the concept was interesting. So I think the protocol was that we were using intraoperative ultrasound, and then if we saw, you know, cord compression or signal change, we would put a lumbar drain in, suck the CSF out, and we did it on one patient who ended up doing well in the sense that he had no neurologic issues after surgery despite a change in motors. But that was it. So it ended up being more like a case report than anything. And then we never really took him anywhere. It was kind of exactly. It's very cumbersome, you know. Yeah. But I mean, there's also, you know, not false positives, but there's, you know, you see monitoring changes, do all the things to go down the algorithm to fix the monitoring changes, and then, you know, a lot of times that's all you need to do. So I don't know what the effect of having CSF drained was, but it was interesting insight into a world that, you know, we typically weren't thinking that way.
Yeah, it makes sense. Thanks, Ryan. That was a great talk.
It also makes you wonder, like in the operating room, if you have someone where you know you have something like that, you know, if you have an intraoperative, you know, monitoring change and you're not recovering well, is that something you should do? should we be prophylactically doing that? Begs the question. Well, guys, have a great Monday.
All right. Thanks, Ryan.
Yeah,
Thanks, Ryan.
Thank you guys.
Bye.